to that today, but I wanted to kind of scope the talk to be like, those GBGBs are what you all might see, but the majority of my patients are out there doing really, really well, really having a great quality of life. So our only disclosures that we are both at Emory Midtown, and so we will bring our both patient experience from that space. I have worked at two other centers and in the bariatric vitamin world, so I'll bring that experience as well. We hope that you leave with the toolkit. We don't have answers for every patient, so we're trying to kind of give you a resource, put this slide deck somewhere safe, and when you get the GBGB, you can pull it out and you'll have the critical thinking skills to make the best decisions for the patient in front of you. When we get the slide up, you'll see I have a QR code because I really like QR codes, so there might be a few. The first QR code is going to take you to a paper by Stephanie Sogg that kind of talks about the best language to use when we're working with metabolic and bariatric surgery patients. You'll hear me use that term, metabolic and bariatric surgery. That is our preferred terminology because many patients are seeking surgery not just for the weight loss. They are seeking it for the metabolic implications. So we say MBS or metabolic and bariatric surgery. The other preferred terminology is using the diagnosis of obesity or using it like a diagnosis. So a patient with obesity or a patient with overweight, I know it doesn't sound grammatically correct, but moving towards that person first or patient first language. If you want more resources on that, I've got a few on that slide about Obesity Action Coalition, the Rudd Center, as well as that those resources have image galleries that you can use if you're putting together a presentation for that space. Maybe we just do it not in presentation mode. Okay, cool, we'll keep going. All right, cool, we'll get caught up. This is what I was talking about. If you're interested in exploring your own bias in this space, because most of us as dietitians, as healthcare providers, we do have biases that we bring to the table. Maybe it's that observational bias that you are only seeing the GBGBs, or maybe it's what we hear from our patients that 70% of them have experienced a bias in the healthcare industry. And so explore your bias. The first thing to do is to be aware of it, and then you can do that using the Harvard implicit bias, which they have lots of different assessments, not just with weight. With that being said, I said most of my patients are walking around doing really, really well. They have 70 to 80% resolution of the comorbidities, including remission in diabetes. They have reduced risk of cancer, and most of all, they have lots of non-scale victories or NSVs that improved quality of life. Again, I wanted to scope the talk with that because we're about to talk about what can go wrong, the complications in the nutrition deficiencies, the need for nutrition support. That's the rare situation. So I also wanted to scope the talk to talk about, we have additional therapies for our patients with obesity now, especially with the increase in the incretin therapies. The anti-obesity medications, as you might hear them called, we're also moving to call them incretin therapies or obesity medication management, OMMs. Those are now available for our patients, and many patients coming to metabolic and bariatric surgery would have tried those at this point. And so I want us to think about that as kind of their weight loss history or weight history when we're assessing them. And we'll talk about weight loss rates and how it relates to that. Currently, the guidelines around bariatric surgery that insurance uses are based on the 1991 guidelines that NIH put out. And in what other space are we using guidelines from 1991? We're not. But the American Society for Metabolic and Bariatric Surgery and International Federation for Surgery came up with guidelines about 2 years ago to decrease the BMI range to that of 30 to 35 with comorbidities and 35 plus without comorbidities. But like I said, insurance has not followed suit. But the reason we're pushing towards that is because we know with the metabolic implications, the earlier the patient can seek intervention from bariatric surgery, especially with if they're not on insulin yet, or if they've had a diagnosis of diabetes less than 7 years, they're gonna have better outcomes. Bariatric surgery, MBS, it's not new. It's been around for a long time, but I did want to talk about the trends so that you can kind of use those critical thinking skills as you're assessing your patient. We have seen an increase in the patients choosing the vertical sleeve gastrectomy or the sleeve. since it became its kind of own procedure around 2012. It used to be the first part of a two-part surgery that you'll see a picture of in a minute, but we saw weight loss with that first part, and it's a shorter surgery, a safer surgery, especially for patients suffering from a larger obesity. So we see that increase in the sleeve. We see a decrease in the band. I have not seen a band, adjustable gastric band be put in since around 2013. And Emory, where I work in the Emory whole healthcare system, has not put one in since probably around that time. We're taking a lot out, and those patients are having what we call a conversion, where we adjust to a different surgery, such as the sleeve, or oftentimes a bypass. So a review of some anatomy, so you can kind of use those physiology and anatomy skills to make your best judgment on what a patient needs. The adjustable gastric band is where we're putting the band. There is a foreign body put into the stomach, the upper part of the stomach, to provide satiety for the patient. The patient would come back about every 6 weeks to get band fills, where saline solution is put in through the port, and they have increased satiety. What happens, though, is to find that perfect spot is difficult, and patients over time might experience reflux and even esophagitis. So we're seeing issues with the band sometimes slipping, or the port placement over time. So more bands being taken out. The other thing you'll see is that that surgery doesn't have a metabolic implication, a metabolic response, and so we're not seeing the same type of weight loss and metabolic benefits as the other surgery. So we're guiding our patients to choose the bypass and sleeve. With the bypass, we have about 80 to 90% of the stomach is bypassed, but it stays in the body. And that's important to remember, because it's still an active organ, still producing hydrochloric acid and enzymes that are then shuttled into the common channel further down, and so still using those. We have 2 anastomoses created, and this is helpful to remember when we're thinking about potential complications. We have our GJ, or gastrojejunostomy, where the stomach, where we call the pouch, connects to the jejunum, and then later on, because we have bypassed the pylorus, the entire duodenum, and the proximal jejunum, the jejunum and jejunum are reconnected to the jejunostomy, and hopefully I don't have to say that too many times during this presentation. We'll call it the JJ, how about that? Then we have our vertical sleeve gastrectomy, or the sleeve. No sleeve, nothing foreign is going into the body, which is something that we sometimes have to re-educate our patients on, and I would rely on you all to do that. It's confusing for folks. No changes in intestinal anatomy. We have a pylorus that's intact, but we still have 70 to 80% of the stomach completely removed. And so we have that metabolic response because of the changes in gut hormones that impact our blood pressure and blood sugars almost immediately. The amazing thing about these surgeries, we're discharging our patients on post-op day 1 with a 50% reduction in their blood pressure medications and 75% reduction in insulin and diabetes medications. Then we've got less common procedures that are more malabsorptive. So definitely keep this in mind. We've got our biliopancreatic diversion with or without a duodenal switch. There is a much shorter common channel. And so we want to read the op notes or try to assess what procedure the patient had, because understanding the length of the common channel helps us know what the risk of malnutrition and micronutrient, even macronutrient deficiencies would be. We do have 1 or 2 surgeons in the Atlanta metropolitan area doing this surgery, but of course we can have someone showing up at our hospitals from outside. And then the SADS, less commonly performed, but it now has its own CPT. It's getting more performed because the American Society for Metabolic and Bariatric Surgery has recognized it as a procedure. It's similar, but one anastomosis, you can see just there's a loop of intestine to create the GJ anastomosis. And we know that with deficiencies, it's falling somewhere in between the gastric bypass and the sleeve. And so supporting the patient in that way. I've mentioned the mechanism of action. Again, this is helpful to remember because we used to think that these procedures were helpful because our patients ate less. You know, there was a restriction, just like the band, but what we know over time is that really they're helping because of the metabolic implications. And depending on the procedure, there may be malabsorption too, based on what I just reviewed. Oops. Ooh, it's flying. There we go. You all probably have seen this picture before, but it's a good reminder of where our nutrients are absorbed. And remember, with the bypass, we are bypassing the entire duodenum and proximal part of the jejunum, so that's obviously going to impact the patient's micronutrient profile. With the sleeve, we are not impacting absorption, but we certainly are changing digestion. There's obvious changes to the stomach volume, which also can impact just how much gastric acid we have and the ability to turn our nutrients into active form. So keeping that in mind. We do see deficiencies in sleeve more so than we see with the band, a little bit less with the bypass, but sometimes our patients might be less adherent because they think they will have less risk of deficiency. I mentioned the common channel length already, but I also want to guide us to assess the patient's ability to eat all foods. If they're having intolerances, especially what we see even with our band patients, if they're not able to eat meat or even salad or some of our vegetable sources, then they certainly can have risk of deficiencies. We actually see high risk or high rates of zinc deficiency with the band. So we'll talk a little bit more about that. And obviously they're just eating less. So in the pre-op space, our bariatric surgery patients are some of the most educated patients in the hospital, whether they can report that or not. They are spending 6 to 8 months typically with their clinic or with their bariatric surgery practice. Now, not all of them have been able to see a dietitian. Some practices absolutely have dietitians, but insurance may or may not cover that preoperative assessment. At the Emory Bariatric Center, they absolutely have had education in a class setting, but they may not have had an individual assessment. Some of our goal is to get them to surgery safely, of course, right? And we do know that abdominal adiposity can impact the length of the time of surgery and their ability to do well with the surgery itself. But I would caution, or we caution our patients on how to lose weight before surgery, because everybody has tried a fad diet who comes through our doors, and many of them have been very successful. Keeping it off is the challenging part. And if we have a crash diet, then they're presenting to surgery with a higher risk of nutrition deficiency. And we see higher rates of UTI and SSI depending on the weight loss before. So instead, we want to maximize their nutritional status by teaching them how to eat with nutrient-dense foods. And we do draw labs before surgery and will replete, but insurance doesn't usually cover another set of bariatric labs to check if that repletion has been effective. So that's something to keep in mind. Most of our patients have, about 20% of our patients will have a deficiency coming to metabolic and bariatric surgery, whether it's just because of their obesity and their ability to access the nutrients, or if it's diet quality. Especially at Emory Midtown, we have a high rate of patients with social determinants of health that put them at higher risk. And so we do try to support them best we can. Surgery, we always weigh the risk benefit of surgery, but additionally, as more and more patients present having taken those obesity medication management medications, then we have a higher risk of deficiency. And they are supported during those medications with a dietitian and obesity medicine physician. So I put up some of the weight loss rates so that you can kind of compare and contrast to the patient in front of you. And remembering, Amber will touch on some of the more common deficiencies with rapid weight loss. Also assess for previous metabolic and bariatric surgery. As I mentioned, many patients are converting from a band to a sleeve or a bypass, but we're also seeing higher rates of reflux with the sleeve. So you may see a patient go from a sleeve to a bypass, whether it's for reflux or whether it's for not reaching the weight loss goal that they were looking for to really have that metabolic effect. And you notice I didn't say success. So I think that's one of the first QR code that I had kind of talks about how we define success for our patients. And it's really up to them to define, and may not be a weight loss goal, but as they get further and further out of surgery, they may have a recurrence of diabetes or other metabolic diseases and seek a different surgery. And Amber's going to come on up and we're going to kind of tag team throughout the rest.
Thanks, Melissa. I do want to highlight one of the things that Melissa mentioned earlier about the GBGBs. This is about 4% of the population that we're experiencing that comes in with complications. So it's a really small amount of people here. These are some of the triggers of why we would receive a nutrition consult in the inpatient setting. A nutrition consult is essential for identifying the root causes of complications and providing appropriate interventions. Patients with bariatric surgery are at an increased risk for nutritional deficiencies, altered digestion, and malabsorption. They may forget to report the past surgeries that they've had or miss follow-up appointments. And we also want to identify the type and timing of the surgery that they've had. Decreased appetite, rapid unintentional weight loss post-surgery could be due to physical discomfort, malabsorption, complications like strictures or infections, particularly in patients who still have obesity. When receiving a nutrition consult for a patient, these tabs here are listed are typically included in our full nutrition assessment. So the reason why the patient came to the hospital, along with their past medical history, their surgical history, including the time when the surgery occurred, anthropometric measurements, and a timeline of weight loss or gain is obtained from the patient. We're reviewing their lab values, indicating deficiencies or elevated levels, which can help us to determine their nutrition status, their hydration status, renal function, or even their diabetes management over time. We're also going to review their medications. Specific to this population, we might see the AOMs, the anti-obesity medications with patients with or without obesity. And we're also going to review their intake of what they've been eating before they came into the hospital, including food, fluid, and nutrition supplements. We're also performing a nutrition-focused physical exam on the patient. This slide focuses on identifying fat and muscle loss in individuals with obesity. We'll also discuss shortly some of the clues you'll be looking for in micronutrient deficiencies in the nutrition-focused physical exam as well. So common areas where excess skin can develop following rapid weight loss include the lower abdomen, the breast, and the underarms. As fat is reduced in the regions, the skin may not fully contract, leading to loose hanging skin. This is likely a sign of significant rapid weight loss where the skin's elasticity does not keep up with the rapid changes in the body composition after a surgery. Also, when we're looking at identifying muscle loss in patients with obesity, I tend to focus on the upper body, especially the face and the neck. Muscle groups in these areas often are smaller and more prone to wasting. Specific areas where it's easy to identify would be the temples, the deltoids and shoulder area, the chest, and the collarbone. Rapid weight loss and poor oral intake can lead to significant deficiencies in essential nutrients like these listed here. So we want to address these deficiencies promptly to prevent long-term complications in these patients. This slide Melissa's going to discuss.
Told you we were going to tag team. So when we're calculating weight loss in the MBS world, we use this funky calculation called excess weight loss. And that wanted to show you that because we have the follow-up slide is kind of a range of what we would expect with weight loss. So to calculate excess weight loss, we take the weight that the patient started with, and then I'm doing quotes because the goal weight is not really their goal weight, but it's a BMI of 25. And so their excess weight loss or excess weight is their starting weight to a BMI of 25. And then we're calculating the percent of that weight loss. You'll also see in the literature, we're trending towards just a total weight loss because that makes a lot more sense and is easier calculation. But our next slide is that reference slide for you. When you're assessing the patient, how do we know if their weight loss is within a normal range or if it's expedited or not appropriate? And so I took from the literature what we know about weight loss rates with the different surgeries, and we have some that are in excess weight loss, some are in total weight loss. And so this is just a guide. We're going to have a quick case study if we have time. The patient in that case had lost about 75% excess weight loss at 9 months with a bypass. So kind of on the higher end of the range, but it's not always super obvious that nutrition-focused physical exam, your clinical knowledge are important as well. We're going to take that knowledge along with everything you know about how the patient is presenting in front of you, take that to combine it with the GASPEN guidelines of if a patient's not meeting 50% of their needs, we do need to do nutrition support. But they are likely not meeting 50% of their needs, even if they're eating appropriately. So we want to think about what's the average MBS patient eating. So I provided some calorie ranges of what we know from the evidence analysis library from the Academy of Nutrition. This is, again, just a guide, but what Amber and I have seen, sometimes that's 600 calories of a sports drink, nothing nutritive. And so we certainly want to dig deeper into what that calories are coming from.
Nope, stop the slide. There's also other reasons why we would advocate for nutrition support for this patient. Are they going to come in, they've had complications, are they going to be coming back for a reversal, a conversion, or another operation? And also the traditional cases of when we would be using nutrition support for a patient: intractable nausea, vomiting, obstruction, ileus, fistula. Nutrition support is indicated whether or not a patient is with overweight or obesity, regardless. There are some items here to consider in the decision-making process when choosing between enteral and parenteral nutrition. It's important to note that a lot of times your TPN or parenteral nutrition is used as a really temporary and great bridge to a tube feeding or getting the patient back to adequate PO intake. So we're looking at the patient. Is the GI tract working? Can the patient eat anything by mouth? And are they having bowel movements? That would be an indication that we could probably use enteral feeding or a tube feeding at this time. Also, is there a fistula present? For patients with a fistula, it's important to determine whether the feeding can occur below that fistula, or if fistula clisis is an option. I have not personally ever done this, but it is in the literature out there. Fistula clisis involves placing a feeding tube under radiology directly into a fistula. There's some cases where that would not be able to be used, of course, but it is out there in the literature. We're also taking into consideration the feasibility of at-home care for this patient. Do they have a good support system? Are they open to doing nutrition support, parenteral or enteral nutrition at home if they have to? We're also taking into considering their vitamin deficiency status and their overall malnutrition status. Also, additionally, nutrition support can be provided overnight or in between meals by mouth for a patient. Next, I'm going to talk about some of the enteral access that we can use for a patient. The next slide is just to show you some of the ways where we can place feeding tubes. So most patients who have had bariatric surgery, tube feeding is often first initially provided via an NJ tube. So given the prevalence of problems like nausea and vomiting, NG tubes are not so likely to be used, but there are certain situations where they may be appropriate. For a Roux-en-Y patient, it's also common for patients to be fed with a PEG tube into their remnant stomach, which you can see here in the picture on the far left. And the other part of the slide shows with the bypass and a sleeve gastrectomy where other tubes may be placed. Also, worth noting that even if a patient has a sleeve that's converted to a bypass, they could still possibly be fed into that new remnant or the new pouch that's created. Also, it's worth noting that the NJ or NG tube would be something for a hospital setting. If the patient needs to go home on a tube feeding, they would be receiving a PEG tube or a J tube in order to be fed at home. When selecting the best tube feeding formulas, isotonic formulas are often kind of the preferred formulas because they match the body's natural fluid balance, reducing the risk of GI discomfort. However, it's interesting to point out that most enteral formulas have a much lower osmolality than medications that they may be receiving and foods that they eat or drink. So a polymeric formula could be used as well. The initial rate should be low and slow to minimize the risk of complications. Oops. And I'm usually choosing a fiber-free formula to start out as well. Patients with gastrostomy or PEGS tubes may also be able to tolerate a bolus feeding similar to a breakfast, lunch, and dinner type schedule between meals or snacks. And for an NJ feeding into the jejunum, my personal comfort level as far as like maximum rates would be 95 to 100 milliliters per hour for that patient. I have read in the literature that there are providers who are doing much higher than that. That's just my personal comfort level. But interestingly, this week I had a patient who was interested in reducing his rate of cyclic tube feeding from 15 to 12 hours. And he did go up to 110 milliliters per hour, which was a success. And he went home on Wednesday. So that was my personal max of what I've ordered. Parenteral nutrition, again, is kind of like our last resort and typically used when enteral nutrition or an oral diet is not feasible. But however mentioned earlier, it can serve as a really great bridge to a tube feeding or eating by mouth at home. So PPN, as we know, can be used from a few days to a few weeks. If a patient is requiring parenteral nutrition longer than that, we're looking at some type of central access to help to fully meet the patient's needs for a longer amount of time.
So there's not a great consensus on how much protein our MBS patients need. If they're doing really great, we tend to let them know 60 to 80 grams, just a very general, and then adjust that based on the patient's height. But oftentimes, while at the time you're seeing them, they're in a higher need of protein. And so going more from that 1.5 up to 2.1 kilograms would be recommended.
Okay, so when calculating nutritional needs for a patient, it's important to use the higher end of the protein range just for some adequate support for the patient. There's no universal consensus on ideal body weight calculations. However, at Midtown, we're using some BMI benchmarks for the ideal body weight. For example, females, BMI of 22 for ideal body weight, BMI of 23 for males, and BMI of 25 for patients who are 65 years of age or older. You can also use the Hamway method if you prefer something a little more traditional, and adjusted body weight is sometimes used in patients with obesity or if a patient is at a certain percentage above their ideal body weight. Also, for calculating energy needs, I'm typically using the Mifflin-St. Jeor formula, not adding an activity factor for a bariatric patient. We're also considering their fluid needs, taking into account the patient's age, renal function, and any fluid restrictions they may have. I also want to point out with these types of patients, when we're communicating with them, it's really important for us to be sensitive and supportive. We want to address their concerns thoughtfully, especially if they express worry about potential weight gain. A lot of times these patients are really pleased with the weight loss that they've experienced and might not necessarily be concerned about deficiencies because they're happy with the weight that they've lost. So we want to ensure that these patients feel supported, and they may not be receiving that from other providers. So just a little thought.
This is kind of a compilation from the literature on what we would recommend for vitamin mineral deficiency or vitamin mineral lab panel. So again, as a reference, and it's slightly different per surgery, know that if the patient is following up with their surgeon and with that practice, they are getting labs about every 3 months in the first year and then about yearly thereafter. But some patients, after the first year or two, we see a very steep decline and loss to follow-up. Something to know, with metabolic and bariatric surgery, we keep a national registry and enter all of our data into it. And so we are calling our patients regularly to get them to follow up. But as you know, life happens and they are lost to follow up. What I'll also say is sometimes they're saying, I follow up with my primary care to manage my surgery. I have never seen a primary care draw all of these labs without guidance from a surgeon, but we do tell our patients, we give them a postcard at discharge to say, this is what you should ask for. So we're hopeful that they at least bring that. What I wanted to also show, they may tell us that they're taking a multivitamin, or maybe they're not, but if they are, it likely isn't supporting their needs. So what I have on the left side is the American Society for Metabolic and Bariatric Surgery guidelines for what our patient, the average patient might need. And then on the right is what our standard multivitamin might contain. And I think it's cut off, but this is for 2 multivitamins, which is what is recommended. And it's still not necessarily meeting those guidelines. And so I'm a strong advocate for a bariatric specific vitamin. I have a few slides to support that. And that can be a bridge as we're discharging a patient who has needed additional care. We're falling most short in iron, depending on what they're choosing. And what I'll also show is that our over-the-counter vitamins and some of our most common ones that I've had my patients take because they're chewable over the years have changed formulations. In 2014, we had one big company change a formulation. They didn't ask me. And then in 2020, another one. So these patients may be continuing to take them without the knowledge that there's the change.
Listed here is a reference of the composition of our commonly used IV fluids. On the lower part of the chart, you can see the appropriate situations of when these IV fluids would be used. The take-home message that I want to stress here on this slide is not to administer any form of dextrose without giving thiamine. Prolonged glucose supplementation without it can increase the risk of refeeding syndrome and Wernicke's, leading to some irreversible brain damage. Next part of this is a banana bag. So we know thiamine is important because it's a water soluble vitamin, and so our body is excreting it very quickly, and it's very depleted in nausea, vomiting, poor PO intake. So we're advocating for a banana bag. If your patient comes in and is malnourished and there's a small amount of time between when the patient is going to receive enteral or parenteral nutrition, go ahead and give that, recommend that. And if you're in doubt, still give the thiamine somehow. If the patient isn't able to eat or swallow, give it to them IV.
And if you do nothing else from today's lecture, what I would love for you to take back to your teams is the education component that's not just for us as the dietitians and pharmacists, but to the surgical team. I know that my colleagues at Emory have done a great job advocating for using that thiamine or banana bag as a bridge to when the patient actually starts nutrition support. We also try to educate our emergency department providers, as well as our patients. We provide this card to the patient to present if they do have to go to the emergency room, as well as there's a lot of education on with the vitamins. They hear chewable sometimes and they think gummy. The gummy vitamins have no B1, no thiamine, as well as they're low in a lot of other nutrients. So we all have tattoos that say no gummy vitamins, but sometimes it still happens. All right, so we're gonna play a little game just to, wake us up this morning. I've put some buzzers throughout the room. We've got one in the last row. There's one up here, and one there. So if you're a competitive person, go find a buzzer. We wanted to provide those reference materials on what to look for micronutrient deficiencies, but do it in kind of a fun way. So we'll have a question. You're trying to recognize what deficiency we're talking about, and then we'll have kind of a reference slide. All right, are we ready? All right, first question. When experiencing, okay, what is it? It is vitamin A. And I wanted to share that I have certainly, here, let's see. So we got night blindness, dry eyes, and bypass spots. I have absolutely had patients with night blindness, more so in our more malabsorptive procedures. There is a revision to the gastric bypass that can be done called a limb distalization, where there is a shorter common channel. And so that's definitely a procedure where you want to identify the common channel length if possible, which if you don't have an op note, you're probably not going to do. But speaking to the patient about, what they know of the surgery, and even trying to contact the surgeon or getting them back to their surgical team. The other thing I wanted to mention about vitamin A, if we're seeing an iron deficiency that is not improving, we may look at vitamin A too, because we know they have a symbiotic relationship in the shuttling of iron out of the liver. The other thing with my patients in the outpatient setting that I'll do is even look at dry forms or water miscible forms of vitamin A. I see better improvement of vitamin A status. And when we look at our over-the-counter vitamins, that is where I certainly see deficiencies in vitamin A, and it's a tricky one because it's not always checked by those primary cares.
In the inpatient setting, I'm usually looking for if patients are talking about any sort of vision changes or problems.
I know we're both looking at skin, and I'll ask them changes to eye dryness is something that I've asked. Okay, this is the reference. It's okay. We had changes to our nutrition labels, as you all know, and if we're trying to kind of do that breakdown of of beta carotene or retinol, which may be helpful for this population. This is just a calculation slide, but maybe kind of erring on the retinol side to see better improvement versus less on beta carotene. Okay, are we ready? Now we're seeing fatigue, spoon-shaped nails, and pica. Ding, ding, ding. That was an easy one, right? Yeah. So I'm certainly seeing iron deficiency heavily in the gastric bypass population. We do see it in the sleeve, especially because iron can be so tricky to take in that oral or outpatient setting. And so playing around with the type of iron and some of our bariatric branded vitamins have a more tolerable form of iron for the patient to tolerate, taking in divided doses with meals. And a lot of times the further the patient gets out of surgery, or if they were one of those that took the over-the-counter that changed formulation, we may need a consult from hematology.
I'm looking for fatigue, hot and cold sensitivities, weakness, low energy.
And if we're looking at the repletion strategy of 300 milligrams 2 to 3 times daily, who can tolerate that and still poop? That's a lot. So hematology might be the answer. All right, we've got changes in taste, poor wound healing, and oh, where would that, is that there? Ding, ding, ding. Yay. So with oral zinc supplementation, it is hard to tolerate. So I would pair it with a protein-based food and or take smaller doses for my patients. Something to definitely think about in this population is that copper to zinc ratio. I have heard of a patient who used a zinc-based cream for their dentures and ended up with a copper deficiency because of it. That was your patient? Yeah. Yeah. So, and in recognizing that zinc is a acute phase reactant.
In the inpatient setting, we're looking at taste alterations, impaired wound healing.
And I think with the rise in COVID, we have more patients taking just zinc alone. And so that would be a trigger to maybe look into copper a little bit more. All right, now we have unsteady gait and neuropathy. I can't tell where this one, so yeah. Yes, you're the winner. Winner, winner, chicken dinner. And I think copper is a tricky one because some of those signs and symptoms do look like other nutrient deficiencies. And copper also a tricky one because it's acute phase reactant. And I often saw high copper rates sooner in that first year just with the stress of surgery itself. What did you want to add?
Copper is also something that's in our trace element when giving TPN, and we can also give additional copper in the TPN or PPN.
We don't always see insurance coverage for testing copper, so you can, in the outpatient setting, so you can assume that maybe that hasn't been followed as closely as some of our other nutrients and look into it while they're with you. Ooh, I gave away the answer, but you all know how to look at for a B12 deficiency. A lot of our bariatric branded vitamins have high levels of B12, which is awesome because it's one less thing the patient has to take. The bad thing is sometimes we see high levels of B12, and depending on the patient's provider, they say stop, which if they're stopping their multivitamin, that's bad news. If we stop extra B12, that sounds good. But if we stop something, we need to make sure we go back. So I almost never stop the multivitamin and just would look at other sources of B12 with that patient.
Neuropathy would be something I would pay attention to in inpatient setting.
And this, of course, is one that we won't recognize right after surgery. It's going to take 5 to 7 years potentially to develop. So look at that patient further out who may need it. All right. Now we have ophthalmoplegia and ataxia. It's a trickier one. I know you know it in the back. Come on. All right, I'll give it to you. We have B1 with thiamine. Those are some less common signs. You know, we want to, the ophthalmoplegia is the change in the eyes, the paralysis of the muscle tissue around the eyes. We might, I already mentioned, you know, if in doubt, we want to give that thiamine, and that is something I talk to my surgical team about a lot. Very quickly, we can see this thiamine deficiency. 2 to 3 weeks is all the storage we usually have. We unfortunately have had a patient, we think about this more with the bypass, but we've had a sleeve patient recently who, you know, those vitamins, because of the high level of supplementation, can be difficult to tolerate, cause nausea. They're already experiencing nausea, so they don't take them and necessarily connect with us to get an alternative. And that patient unfortunately did come up with Wernicke's encephalopathy.
Along with that, any type of confusion with the patient, we might be looking at this deficiency.
I did also hear a report of a patient who was taking the kidney formulations of vitamins, which are lower in the thiamine, and they had the changes in gait, which was how they recognized the B1 or thiamine deficiency. So you did great. Thanks for playing along with my buzzers. I wanted to provide that bridge for you of, okay, a patient, we've supported them, we've looked at their micronutrient deficiencies while they're with us inpatient, and now how do we bridge them back home? So looking at what kind of trends are available with our supplementation. I already mentioned we have changes in the over-the-counter vitamins. So instead of just saying, are you taking a vitamin, dig a little bit deeper, how many are you taking, even if you have an opportunity to look at what the nutrient profile, because even in our bariatric branded vitamins, they can vary quite a bit. And it's just to match it with what the patient really needs. So these are the changes over time with the vitamin A, iron, and zinc and copper, which can certainly make a difference in. We also know adherence is a big deal. If a patient's not taking a vitamin, well, we're going to see deficiencies. But you'll see from, I'm going to go forward for a second. Too far forward. If we have that over-the-counter non-branded schedule, who could follow this? It's very difficult. I certainly couldn't, and that's why I push for the bariatric branded, because it's a little bit simpler, but still a pretty big commitment. So kind of matching the patient with what their preference is or what they need to be able to do with their supplementation. So going back, I already mentioned that oftentimes they're lost to follow-up. And so again, you can be that bridge to get them back to their home team, or getting them, it could be the surgeon that's following them while they're inpatient, or getting that consult so they can be connected back with a bariatric surgeon. Any accredited program, so at Midtown, we're a MBS AQIP accredited program, so is St. Joe's and Decatur and Johns Creek in the Emory system. We should take on patients that come to our doors. One of the biggest reasons patients aren't following up is weight recurrence, which is the preferred language to use in this population. They feel ashamed. They feel like they let their team down, but it's kind of letting them know that it is common to have some regain, and that our door is open wider when they experience that. So what I wanted to show here is kind of that difference between using the bariatric or specialized formulation and just an over-the-counter or standard. And so from the middle graph, we see that black line is the standard formulation, so higher rates of deficiency because just lower supplementation. One of the biggest barriers to those supplements, what I hear from my patients, is the affordability. And so I wanted us to guess, if we're buying an iron, we're taking 2 multivitamins, a B12, B complex, and a vitamin D, how much are we paying a month? I already flashed it, so I'll just do it again. It was around $15. And so then if we're just buying 1 bottle with the multivitamin, and in both cases, we still need to buy calcium, it's more, but not significant. So again, we're matching with the patient's need. If that $3 upfront cost could make a big difference to some of our patients, then we want to support them with the other set. But for the ones that doesn't, we can do that education. And I already showed you my schedule. And we're going to talk about CJ. She is a patient that both Amber and I have worked with, and probably many of you in the audience. She did not have her index surgery with us at Emory. She had a surgery in Macon, and then came to us for care with kind of chronic complications, we think related to her smoking status, which with the bypass is a big red flag, because it's it's a ulcerogenic procedure, and that is what she is experiencing. We also know that she has challenges getting food, those social determinants of health. And Amber's going to talk a little bit more about her.
All right, so she came in with, sorry, I know, like, here we are. So she came to UHM with complaints of abdominal pain, worsening weakness, and decreased oral intake. So shortly after her admission in February, she underwent a lysis of adhesions, repair of her JJ anastomosis, placement of an omental flap, and a G tube insertion. So also complicating things for her, she has a GG fistula, which is connecting her gastric pouch to her remnant stomach, and she's had several wounds since this time. So at Midtown, we were consulted to to begin CPN on post-op day 1 for bowel rest. At this time, she was in the ICU, intubated, sedated, on pressor support, and even temporarily requiring CRRT. So again, her post-surgical course has been complicated by recurrent ulcers, likely exacerbated by her continued smoking. She's been, in and out of the hospital since February. This here is a little bit of her weight history. It's not on this slide, but this particular patient, when Melissa was talking earlier about the excess body weight, before surgery, she had about 178 pounds of excess body weight. And at the time of her admission to us in February, she had lost about 75% of that, putting her at a loss of 43% of her weight loss, which is slightly above what we would see on the chart at the beginning of the slide with average weight loss in the timeline for this person. This patient also has CHF, so we have some fluid shifts and changes. So weight isn't necessarily a super reliable way for us to diagnose her with malnutrition each and every time that she comes in, but she's most likely meeting the malnutrition criteria because of poor intake, unable to tolerate some of her tube feeding at times, which we'll talk about in a minute, and also the nutrition focused physical exam. So especially in her clavicles, in her temples, in her orbital area, we're seeing signs of severe malnutrition with CJ. A little too far. Oh, I thought this one was this way. Oh, yes. Okay, so CJ is a frequent flyer with us, so our goal for her is to optimize her nutrition so that she can undergo a surgical takedown of her GG fistula and a possible bypass reversal. So when we began nutrition support on her CPN post-op day 1, she spent 26 days on TPN with us, and during that time, we were trying to feed her through her G-tube, which was placed in surgery. So her initial tube feeding started with a 1.5 calorie formula, high protein. She was getting 1 packet of a protein supplement every day, and her original goal rate was 45 milliliters an hour, which she was tolerating. We had tried to change her to a bolus feeding, but she wasn't able to tolerate that. So we settled on the 60 milliliters per hour over 20 hours. Since this time, since she's been readmitted to the hospital, and since I've made this slide, she's currently doing 80 milliliters an hour over 14 hours. And in addition to her cycled tube feeding, she's also at times able to do full liquids and high protein oral nutrition supplements. This slide shows the supplements that CJ is supposed to be taking at home while we wait for her optimization so she can return to surgery. So she was actually scheduled to come back for an outpatient appointment in August, which she was a no-show, and she also rescheduled another appointment. So hopefully her surgeon will see her at the end of this month to talk about her nutrition optimization for potential return to surgery.
But obviously this is a pretty heavy supplementation load, and so definitely something to be keep in mind in checking with repletion, because she's likely not able to keep up with that, and that was, another reason for her inpatient support of the repletion. So we have another case study. We did not plan to have time, but I always like to show my surgeons drawings because it really helps me. And so always ask them, like, what is going on? And they will draw it for you, because that's part of, I think, med school, where they take a drawing class. In short, we want to optimize before surgery. So in this patient's case, where we were planning a revision or reversal, and then it's often an interdisciplinary team discussion, and or the dietitian, pharmacist, whatnot, is advocating for the nutrition support. Our surgeons sometimes get blindsided by the patient's losing weight. That's the goal. And so reminding them, if they're not meeting their needs, it's not a healthy weight loss, and supporting the patient. And even we might be that person to educate on the anatomy. I've had patients very confused about, how can you not feed into my stomach? I clearly have a lot of stomach left. So reminding them that's a tummy or abdomen versus the actual stomach anatomy. I put some resources, one of which you can get from the raffle, just as a guide if you're making these decisions moving forward. And I promised I like QR codes. This is some resources on how Emory manages micronutrient deficiencies. And I used to work at Brigham and Women's Hospital, so I threw that up there. And if your patient is struggling to purchase the vitamins, these are 3 resources for financial aid. And if you have follow-up questions, we can take them now. We have a few minutes, as well as you can connect with Amber and I after.
If there are questions from the audience, we ask that you go to one of the microphones so our Zoom attendees can hear as well. Thank you. And if there are questions from any of the Zoom attendees, you can either put it in the Q&A section or in the chat.
I was just wondering about, you were talking about the multivitamin formulas, like the big companies changing formulations. How does that affect, like, does it decrease the nutritional value, or like what's the most common change you've seen in like nutritional result of the result?
Yes, I have never seen an increase from, and I'm talking kind of more about our over-the-counter, like what our children used to take or what we used to take as children. That's, you know, the brand I'm trying to talk about. That one changed in 2020 and it decreased the vitamin A significantly, changes in iron quite a bit. Those are the 2 nutrients I've seen them change the most. So great question.
And how often do you see those changes? Like every 2 years, every year?
I saw a big one in 2014 and then 2020. No one sends a mass email to the bariatric dietitians though, so it's, you know, kind of checking back regularly. I also say that our bariatric branded vitamins, they try to use the literature and those ASMBS guidelines to match their formulations, but there's always changes in interpretation to the guidelines. Our newest guidelines are for 2016, and I can say that one of the vitamin companies drastically reduced their iron because of how they interpreted the guidelines, and then we saw a change because that is not what the industry wanted. So
Thank you.
yeah.
We do have a question from one of our online participants. Do you use indirect calorimetry with your patients?
I wish that we had that. If we have a sponsor out there that would be willing to donate to Emory Midtown, we would love you forever. But unfortunately, no. Working on it though, maybe.
Another question, have you seen a decrease in the rates of surgeries with the GLP-1 agonists being on the market?
Yeah, we are across the nation. I've surveyed other bariatric coordinators and we are seeing that decrease. So the way we're responding at Emory Bariatric Center is to provide additional access for the non-surgical route. And a lot of our bariatric surgeons offer that in a comprehensive center. And when I'm guiding patients or family members or people in the public, those type of programs are ideal for supporting those patients versus, in my opinion, you know, your cardiologist or primary care prescribing them, because we have worked with weight loss, you know, that's the patients we work with. We know to check for those micronutrients. As I mentioned, 20% of our patients just presenting with obesity have deficiency. So we know then with reduced volume of food, we might have a higher risk. There's a comprehensive approach too. They have a mental health provider, they have dietitians, versus, you know, a primary care who has 15 minutes to talk to their patient and doesn't necessarily have the training or resources to support more. Yeah.
Hi. I was just wondering how you address like results of iron, like high iron supplementation or like chronic narcotic use in like bariatric patients and like constipation or other GI issues.
Yeah, well, I can speak to, we do absolutely see constipation around the time of surgery. So prior to surgery, many patients are on a liver shrinking diet that's kind of high protein, low calorie. And so we start them off typically on a supplement to help them. I don't know if I can say the brand, the Miralax before surgery. And then we, polyethylene glycol, there we go. We'll start them back on post-op day 2 and kind of, we were seeing, you know, ED visits from constipation. As far as related to opioid use, that's part of the education at discharge too. We still are using oxycodone as at discharge, but there's a lot of guidance on multimodal approach, and that's part of the education that I provide, and at follow-up too. And Johns Creek is doing a project, a national initiative to reduce opioid intake or opioids prescribed during their inpatient stay and at discharge. Long-term, that's outside of my scope, but I can try to address a specific.
Oh, well, I guess just like if a patient like goes home, like and they ask like, oh, should I continue doing Miralax at home or some, or, oh yeah.
Yeah.
Glycol.
Yeah.
Yeah, and like what?
Yeah, certainly in the beginning too, in the first couple of months after surgery, they're having very little fiber, and even long-term, we try to recommend a whole foods balanced diet, but protein being the primary nutrient that they need when they're having low calorie intake. So often they are doing some polyethylene glycol, potentially fiber supplements over time. And fluid is another big reason where they may be experiencing constipation, and that is I get on my soapbox while they're in the hospital to talk about fluid. We are having them track while they're in the hospital post-op. We ask them about their fluid at a post-op call at their follow-up. And so that is absolutely a long-term part of our nutrition counseling. Yeah.
Thank you.
Another question from our virtual attendees. With the current controversy circling BMI, do you think the parameter will be dropped in bariatric care?
Well, in 2022, we attempted, with our joint organizations making that updated consensus, and we just need our insurance companies to follow suit. As far as BMI, we recognize on the bariatric surgery side that that's not the perfect marker, and we would much rather see other markers of metabolic health, be used. But we're kind of tied to what insurance will cover. And so it continues to be what we use. But I'll tell you, it's not what we're talking to our patients about. And we are able to do some anthropometric measurements and bioimpedic measurements to help the patient have different goals rather than just a BMI based. Yeah.
I've got one more. Does insurance cover bariatric multivitamins cost?
No. Wish I had a different answer. We sometimes have like written prescriptions for over the counter or whatever the pharmacy has to at least get the patient coverage or to help with the finances. But as I showed you, those are different, very different formulations. And so that's absolutely part of our discussion pre-op too. Is this patient, is the risk versus the benefit of the surgery? If they can't afford vitamins, let alone the bariatric vitamins, if they can't get access to food that's going to support their surgery, we have multidisciplinary meetings to really discuss if it's the best approach for the patient. But I have this slide with the support for the financial support for those patients too, but sorry. Yeah, I wish. Thanks, everyone.
Thank you.